more time to start. So if I just introduce myself quickly, I'm James Dilly. I'm one of the trainee representative for the BGCS. Unfortunately, I'm having issues with my webcam, so you can't see me, but you can see Alec at the top there. So if I introduce Alec as our first speaker, he is the chair of the RPOG Curriculum Committee and has been very involved with the recent changes that we've had. Just prior to Alex starting, just a couple of things. If you want to ask questions, there's a question box. Put your questions in there, and John and Anne will make sure they get asked at the end. Alex is going to speak for about 20 minutes, and then we'll have about 10 minutes for questions. So I'll hand over to Alec now. Thank you.
Okay. Thanks very much, James. And thank you for inviting me to speak at the conference today. I am going to remove my webcam so that I can read my own slides, because otherwise, unfortunately, my face is right in the middle of my screen and I can't do anything about it. So yeah, I'm going to say goodbye facially, at least for the moment. Jonathan, yeah, can everybody else turn their webcams off, because I don't know how to. Yeah, Jonathan, thank you. That's brilliant. I can see my own slides now. So I suspect that this talk will be relatively challenging to much of the audience. And some of what I say will also be, I think, repeated by Joe Mountfield, who is speaking half an hour later or something, on issues which overlap, but I don't think it does any harm to hear some of those key points twice from two different people. I will just say at the beginning of the talk that I am not responsible for the decisions that have been made. I have contributed to them and I am behind them, but the issues that we're going to discuss have been issues for quite a considerable period of time, predating the introduction of the new curriculum. But there is no doubt that the 2019 curriculum has brought things very much to a head. So with that background, let's start. Oh, hang on a moment. How do I move my slides on, guys, on this format? If somebody else wants to do it for me, if not,
I'll share my screen if that would help.
Let me just not sure how it's not responding to my usual arrow.
No.
Let me just go into this.
Elaine, are you around to give some guidance?
I think
Christina, Alex, are you in your PowerPoint?
I am in my PowerPoint, yeah.
Yeah, so it should, can you use the arrow keys to forward it on like usual?
No, I've just tried that actually, and it's not. Oh, here we go.
Right, down the bottom right, there you go.
Okay, thank you.
Great, thanks, Christina.
Okay, so as you know, you can only be a subspecialty accredited gynae-oncologist if you have an O&G CCT. You don't have to have the CCT before you start your subspecialty training, but you cannot be an accredited gynae-oncology subspecialist without a CCT, and for most folk that will mean a UK CCT. So the award of a CCT in obstetrics and gynae obviously means that you need to have completed both the gynae and the obstetric aspects of the core curriculum. And how things have changed is that, of course, with the 2013 curriculum, you were able to complete the advanced competencies, those dark pink boxes, those advanced core competencies. Those could be actually completed at any point in your training program. And so some trainees that were ahead of the game would have completed those before entering ST6, and that was permissible. And certainly many trainees entering subspecialty training would only have 1 or 2 of those dark pink boxes to need completion during their subspecialty training. And so that wasn't unduly difficult and didn't cause any major problems, and was effectively saying that you can be awarded your ONG CCT based on evidence that you had collected really principally up to the end of ST5, with maybe a few other bits in ST6 and ST7. But things, as you know, have changed with the 2019 curriculum. Sorry, I'm doing that again. And now with the 2019 core curriculum, that requires that you provide evidence for key skills in the core CiPs through ST6 and ST7. You need to be giving evidence of those core key skills and competencies from clinical situations and educational opportunities that you have accessed during your ST6 and ST7 levels. And so, of course, we are talking about the clinical CiPs, the emergency and the elective gynae, if you want to call them that, and the emergency and the elective obstetrics. And we are also talking about the generic CiPs. They all require evidence which is collected during ST6 and ST7, and you cannot be signed off, as it were, at ST6, ST7 level for those CiPs, those core CiPs, before you have entered ST6. And of course, to a lesser or greater degree, that causes significant challenges for those trainees who are doing subspecialty training. I'm an obstetrician, I'm a fetal medicine subspecialist. I was not expected really to collect anything significant from the point of view of gynae competencies during my subspecialty training. But as a fetal medicine subspecialty trainee now, those trainees will be expected to collect evidence of ongoing key skills acquisitions across gynecology, as well as across the generic CiPs. And so for this audience, of course, the converse is true, that you will be expected to collect evidence that shows ongoing development of your skills and competencies in the core obstetric skills. So this is the summary of the core CiPs, which I'm sure most of you are becoming more familiar with, and that just lists the 4 clinical CiPs as well as the other 10 generic CiPs. So, you know, what is this actually practically going to mean for you as a group of subspecialty trainees in gynae oncology? Well, what it's going to mean will very much depend on what type of gynae onc subspecialty trainee you currently are. If you are on the 2013 core curriculum, and I expect some of you still are, it will mean very little at all, and you can probably give a huge sigh of relief. You will only be expected to have evidence of completion of the dark pink boxes as you would have been previously, and many of you will have those signed off already. And if you haven't, it's not particularly difficult to get those, to get the evidence that you have reached those skills and competencies. So you guys don't need to be too concerned. There's nothing new for you to have to think about. If you are a gynae onc subspec trainee who is post-CCT, whether it is a UK CCT or a European CCT, you also have not too much to be concerned about. You basically have reached the requirements of that general CCT, and you can focus on your gynae-onc capabilities in practice, and you don't need to concern yourself unduly otherwise. There is some guidance on the website for that group. If, however, you are on the 2019 core curriculum, as some of the newer gynae-onc subspec trainees will be, and of course virtually all future gynae-onc subspec trainees, unless they already have a CCT, will be on the new core curriculum, then things are potentially more challenging for you. Now, many gynae-onc subspec trainees are still on an on-call emergency out-of-hours rota, and the challenges are fewer for that group because they will have good opportunities to show their ongoing development of obstetric emergency skills, and some of that I think will spill out into the non-emergency core obstetric requirements as well. I think the biggest challenge will come to those trainees who do not have obstetrics as an out-of-hours commitment and are purely working in gynae-oncology services. So no obstetric on call, no general gynae on call, just working as subspecialty trainees. And there are a small number of gynae-onc trainees, I believe, in that position. And the most challenging will be for those trainees who complete ST5 and move into ST6 without a general emergency on call in obstetrics and gynecology. For those trainees, there are going to need to be some very careful plans made as to how they can possibly achieve the core skills to an ST6-7 level in the areas of the curriculum which don't overlap at all with gynae-oncology. So what this means will depend very much on, as I say, what type of subspecialty trainee you are. But I will focus most of my discussion on that group of trainees who do have a general on call and who are on the new curriculum. Let's just move on. Jo will talk about this in a little more detail. I hadn't realized that she was speaking and I don't want to steal her thunder. What she will tell you is that historically, the RCOG has very much been fudging this issue. We have been giving people a CCT in obstetrics and gynecology, knowing that really as advanced trainees, they have been predominantly focusing on particular areas of gynecology or particular areas of obstetrics if they have been doing subspecialty training. And although the majority of those subspecialty trained individuals will go on to work in subspecialty areas, by no means does everybody with subspec training take on a subspecialist post. And even if they did, the fact remains that the GMC will not allow us to split gynecology and obstetrics into separate training programs with separate CCTs. And so unless we continue to fudge it, we have to agree that those trainees completing training with subspecialty training as part of that do need to have met all the requirements of the core curriculum. And so with that in mind, and I think that that is now beyond dispute, and so with that in mind, there have been different options considered for how we can make this work with the subspecialty training programs. and they're listed here really, and I think Joe will talk through them in more detail. But you could, for example, suggest that you can only start subspecialty training when you already have your CCT in O&G. And although many find favour with this idea, there are some very complex funding problems, because deaneries will not fund training posts for folk who have already got their CCT, or that's what we are led to believe. So then there would become a real issue with who was paying for that post-CCT trainee in subspecialty training. We could ensure that all subspecialty training programs include an obstetric on call with exposure to antenatal care. That, in the current environment of gynae-onc training, of course causes great concern, because I think there is much sympathy with you that completing the requirements of gynae-onc subspec training in 2 years of clinical work is a big ask, and is probably, for the majority of trainees, verging on impossible to do. And here we are, and indeed an obstetrician is here saying to you, well, you need to do some obstetrics as well within that training time. So that's a very challenging point, and we do recognise that. So an idea which again has much support but also has its problems is that we suggest that you can only enter subspecialty training when you have completed ST6. So you have had a year to show your competency at that ST6-7 level with all those core skills that we've been talking about in the core curriculum. The downside of that, of course, is that it limits the window of when you can apply for subspecialty training programs. At the moment, some heads of school and postgraduate deans will not support entry into subspecialty training during ST7. However, it would mean that during that year of ST6, particularly for the surgical specialties, there would be that opportunity to get some operating before you then start as a subspecialty trainee. I can only imagine the challenges for a new ST6 starting gynae-onc subspec training with the very poor exposure they are likely to have had with gynae surgical training in their normal general program. And similarly, from the obstetric point of view, it's very difficult taking on a brand new ST6 who really hasn't done much ultrasound scanning into fetal and maternal medicine subspec training, because you spend the first year trying to teach them how to scan when that's not really where the focus should be. So there are analogies in both on both sides of the specialty, I think. It has been discussed about whether gynae-oncology should be divorced completely away from obstetrics and gynecology and be part of a general surgical training pathway. For the vast majority of RCOG members, that is not considered an acceptable or sensible approach. So a difficult one, this, a very difficult nut to crack. So I thought I would just show you what the key skills are for the obstetric core CiPs, because those arguably are the ones that you would be most concerned about as a gynae-onc subspec trainee. But I think we mustn't forget that actually the type of gynecology you're doing is very specialized, and there is a wealth of other gynecology which you do not address during gynae-onc subspec training, and which is raised in the gynae core CiPs, which you will also need to be very mindful of as a pre-CCT gynae-onc subspec trainee on the 2019 curriculum. But anyway, let's pick the obstetric ones, because those undoubtedly will cause the biggest challenges. And you know from the talks about the new curriculum that we have these headline statements. The doctor is competent in recognizing, assessing and managing emergencies in obstetrics. And then within that, we have a list of key skills, and those are all the key skills. And each of those key skills, it has been decided, you as a gynae-onc subspec trainee would need to provide at least one piece of evidence for each of those key skills. And the more sophisticated and the richer that piece of evidence is, the more likely it is that somebody will consider it adequate as evidence that you are able to operate in the loosest sense of the word at that ST6-7 level. So for the generic CiPs, we talk about meeting expectations for ST6 and 7. For the clinical CiPs like this one, we talk about you needing entrustability level 5. That's the kind of elective obstetric CiP, and arguably that might be the most challenging, because for those of you who are doing emergency obstetrics, the previous one shouldn't prove to be too difficult, but this one may be more difficult. And this is where we will need to be clever and efficient in the way that we encourage you to collect evidence and how to access that and be guided, so that you are proving what we need you to prove, evidencing what we need, but also not spending a disproportionate amount of time on this when really you need to be focusing on your gynae-oncology. We mustn't forget the core procedures in advanced training. They are listed here. So on the matrix, surgical management of PPH, complex cesarean section, ovarian cystectomy and laparoscopic ectopic are the 4 procedures that you will not have needed to prove that you are competent at before starting your gynae-onc subspec training. They are usually acquired over the course of ST6 and 7. What do we mean by surgical management of PPH? Well, we've made that clearer very recently. So the newer versions of the matrix state quite clearly that we are talking about the use of balloons, brace sutures or hysterectomy in the recently delivered patient. Complex cesarean sections, well, that's quite a broad definition, but those are some examples there. And ovarian cystectomy, I can't imagine that will cause any of you any difficulty. It is worthwhile just emphasizing that laparoscopic ectopic, of course, will be a required skill and not one that I would imagine most of you would struggle with. But nevertheless, you will need, by the completion of your training, to show 3 summative OSATs showing that you are competent. You do not need to show ongoing competency anymore. So these procedures and their competency can be achieved before you enter ST6, and you will not need to show evidence of ongoing competency thereafter. So as an ST5, if you do a whole series of quite difficult cesarean sections and folk are happy with that, then you won't need to provide any more evidence during ST6 and ST7. But that's just for the procedures. For the key skills, you will need to show evidence that you are reaching entrustability level 5. So, sure. Am I running out of time?
I'll just let you know we've got about 10 minutes left, 5-10 minutes left. So if you want to speak about this slide, that's very good. There's a few questions, but I think actually most of what you're talking about is answering the questions. So sure. I'll let.
I think this is
keep
probably
going. I'll let Jonathan and Anne step in if they feel that we need to. Any burning questions we're not covering.
Okay, so strategies for how you guys find your way around this. You could enter gynae-onc as a CCT holder. You could apply later for your subspecialty training post, if that is going to be permitted within your deanery, so that you've acquired these core skills to ST6-7 level before entering gynae-onc subspec training. You could make sure that you are doing a gynae-onc program where there is an obstetric on-call commitment. We may need to, on an individual basis, design programs where there are timetabled opportunities to access the right kind of obstetrics, and to do that efficiently, like I said, but nevertheless to recognize early on in your subspecialty training that these are commitments that need to be reached, and so having a plan at the beginning rather than it all being a problem at the end is very much the way forward. I think we should be talking about you guys having an obstetric clinical supervisor. Going through this evidence, you can't do that with your gynae-onc supervisors. You will be much better guided by having a link obstetrician that will help you find your way through this. Know these core tips really well so that you can grab every opportunity that you are involved in to use that as pieces of evidence for supporting your senior advanced sign-off. And look for areas of overlap. I've got a slide in a moment which highlights that. And remember, the evidence that you are collecting during subspecialty training is potentially useful for, at the very least, signing off those generic core CiPs. So don't forget about those. Remember that they need to be done, but use the evidence that you are collecting already for your gynae-onc subspec training to be signing off the generic CiPs. And so these areas of overlap, really, are there any areas of overlap between gynae-oncology and obstetrics? Well, I racked my brains, and I think these are potential areas where actually it's pretty good as a gynae-oncologist to have an idea of what it means to be lopping off bits of cervix of a woman who then goes on to have a baby in the future. So preterm birth clinics are not without their value to you as gynae-oncologists. Abnormally invasive placental services are really beginning to get themselves organized now. And whether you like it or not, as gynae-oncologists, you will be expected to form part of the workforce that actually helps us as obstetricians manage this increasingly large population of women who have morbidly adherent placentas, because we can't do the surgery. And certainly in Nottingham, it is principally the gynae-oncologists who support our lead obstetrician for this service. So get involved in that during your gynae-onc subspec training. Use that evidence, but use those experiences as value for your future role as part of our workforce. Obstetric medicine clinic.
Alec,
yeah.
can I just
Sure.
I just finish up there? We're just closing towards getting towards the end of time, and I think Anne and Jonathan have got a couple of questions.
That's fine. Fire away.
Okay.
I just conscious of the time, I'm afraid.
So there are a couple of pertinent questions here that have been posted by members of the audience. One is, I'm confused as to why you can have core procedures signed off prior to ST6 or 7, but not key skills. Were you able to explain the rationale behind that?
The philosophy, the idea is that clearly evidencing to an ST6, ST7 level requires that greater amount of exposure and that greater maturity of the trainee. I am sympathetic to that question. Our subspecialty trainees, not always, but do tend to be are high flyers. And so it is possible, I think, for somebody who is ST5 to actually be performing at an ST6-7 level if they are an exceptional trainee. That was raised in a discussion and was quashed as an idea that trainees might be able to be signed off to those levels prior to actually entering ST6-7. And there are some good and not so good arguments as to why that should be the case. And I will be interested to see what Joe Mountfield says on that, because Joe has some thoughts on that. And I think it's a very fair question to ask.
I think it's the obvious.
Tell you that there is anxiety that if we start to sign people off at earlier parts in their training, then the GMC will say, why is your training program 7 years? There's all these trainees that you're managing to sign off at senior level before they enter ST6 because they want to do gynae-oncology. And do any of your trainees actually need to do years 6 and 7 to get these core competencies? So that's one of the not so good reasons, I think, for saying that, but I haven't got anything better to offer you at the moment.
It's a potential solution, isn't it, to this issue if it was able to work, because it would be reverting back to the previous situation.
It would be, but I don't know that there will be an appetite to pursue it.
Anne, did you want to ask?
I think the questions coming through really are along the same lines about maintenance of skills or current competences for people who've joined in late ST6 and 7. And I know that you previously of what would be acceptable for their previous obstetric sign-offs, but we're getting quite a few questions about that, sort of those current competencies during their sub-spec training.
Well, if they are on the new curriculum, then at the point that they are about to enter subspecialty training, the sensible thing to do is to send those ticket requests of the core capabilities in practice to their current educational supervisor and say, look, I think I've got enough evidence for you to sign me off as entrustability level 5 on the clinical CiPs and meeting expectations for ST6 and 7 on all the generic CiPs. Do you agree? And if that supervisor says, yes, I agree, then they don't need to do anything more because they have reached those requirements of the core curriculum, which is one of the rationales for supporting this idea of entry a little bit later in ST6-7 rather than knocking on the door when you've just finished your ST5, which I think actually amongst the gynae-onc trainers, they have understandable anxiety about, because those trainees rarely have had much opportunity to flex their surgical muscle. And just as there will be some trainees who do not have the surgical skill to be gynae-oncologists, however long and hard you train them, there are some trainees in obstetrics who cannot learn to scan to the adequate level. Not many, but there just are some people who do not have brains that are wired in the right way. And that's the same for surgery and scanning and needling. And to find that out before somebody actually commits and gets appointed into a subspec training program surely has to be beneficial.
Great. Alec, thank you very much for that. Jonathan, Anna, do you have anything else pressing or in the interest of time?
The last theme here is really looking at the issue of the placement of well, what we can learn from the Royal College of Surgeons in terms of all of their consultants aren't expected to have competence. You wouldn't expect a hip surgeon to do a liver resection or vice versa. And is there anything we can learn from them to solve this?
That's also a very good point. And unfortunately, our analogy, I think, is to say, well, that's why we have our advanced training skills modules. We don't expect everybody to be able to do an ultrasound scan for a fetal anomaly. And we actually don't even expect everybody to be able to do a hysterectomy anymore. But there is a core level of skill that we expect all obstetrician and gynecologists to have when they complete their training. Now, whether we review that again and say that could be diluted down even further. But what you've got to remember is some of you guys will actually go into consultant posts where you are doing obstetrics. Not many, but some of you will. And so there is, again, probably no appetite for reducing further what is a relatively low bar in core training where obstetrics and gynecology are concerned, really.
Wonderful. Thank you very much, Alec, and thank you for the questions. In the interest of time, we're probably going to have to move across to the next speakers, but I'm sure we could all talk about this quite a long time. It always generates quite a lot of discussion about how things are moving.